All right, we got 16 people, looks like, viewing us.
All right.
Hey, hey.
Something.
All right.
Working through the inevitable first go-around. The inevitable first go-around technical challenges, right?
Of course.
All right. Well, I'm Scott Wildenheim.
John Hill.
Dr. John Hill.
Caleb Ferroni.
And Caleb Ferroni. Now, do we or don't we have our colleague Ray Pace streaming?
We do not. I don't see
We
him
do
in
not.
there.
So we see Ray. We can see him. He's right here. I don't know if
We don't see him up there, Ray.
we don't see if, and we've got our live stream comments up there.
Sweet.
5 listening here with Richard Smith. This is fantastic. So I guess let's start with, why are we hijacking your devices at 4 o'clock on a Monday afternoon on behalf of university hospitals? And the whole pretense here and the whole concept is we're doing this podcast, the Prehospital Paradigm podcast, as part of the EMS Institute, and we're pre-recording. If you haven't seen these episodes, we're pre-recording these episodes. They're generally fairly lengthy, and what our goal is to give you like half-hour, 40-minute snippets of them each week, right? So we'll record long and then edit short, and then every week we're gonna put out a component of that, both as an audio product and as a mixed audio and video product on the YouTube channel. So there is, of course, having said that, there's a YouTube channel sale over there, EMS Institute, and then you'll find the audio video product there, and your usual sources for podcast for the audio only. As I understand it, that should be on iTunes. That should be out there on many other platforms. Again, this is new to us, so I don't know in its entirety as to what we're out on quite yet. Well, obviously, we'll get some clarity on that. There's a broker that goes out to the world, and I don't exactly see every single streaming service that goes out to. So I'm going to cut that up over the 3 weeks, and then this fourth Monday, we're supposed to be doing this live program. So.
Kind of a Q&A and a recap.
Ideally, it's going to be exactly that. It's going to be recap, and then hopefully we get some feedback, or we get some questions from the outside world, and I'm hoping that we can maybe stitch together 3 or 4 complete sentences to answer said questions, or at least address them. So, John is stepping out for a second to fuss with.
He is in a sympathetic state.
Yeah. We lost our. Did we pop out, John? Or?
I mean,
he's trying to get.
We know that the first couple are going to be. We're getting to learn this.
Yeah, absolutely. So. Oh, there's a hi. A few other people. A couple other names that.
I don't know that Fallon.
So, well, while he's trying to troubleshoot some technical stuff.
Yeah, give us a recap on episode 1.
Yeah, I mean, let's get into some of the stuff about episode 1. If anybody has any topics that you want us to expound,
I'm just gonna stand.
You're gonna stand? That's fine.
Why don't you go middle?
We're gonna rotate.
Musical chairs.
Yep.
Yeah. Oh, Scott! Now I know why you like this seat. This is nice.
I know. No, it's got good audio.
All right.
So one of the things, as we were watching on the way here, I was doubling down, looking at rewatching those episodes, and one of the things that kind of overarching discussion that I think needs to be had or restated is you got to know your equipment. And you got to know what you have and how to interface with it, especially if you're getting it from multiple sources, right? If you go to multiple hospitals and you're getting equipment from if you're getting it from this hospital and that hospital, you have to be John on spot. You have to pay attention to that. I mean, I was telling John before you got here, just this week, and I helped drop some CPAP devices off to a department we were bringing on board, our med control, and dropped the things off. And as I'm walking away, I'm like, I just literally dropped them off. I had no idea what kind of adapters they had in their truck. I had no idea if they could go out and use them.
You use these, or?
Yeah, I was dropping off some of these disposable pulmodine systems. And, it was this mad panic. It was just like, we got to get these guys some adapters, right? And we got to figure out what they're using, get them some adapters. And it's a quick, simple oversight, something like that really could have caused. Now they weren't going to be using them that day. I mean, we were in no real danger. But the point is,
knowing your equipment.
You got to know your equipment. You got to know what's going to adapt into your vehicle. We talked about the different sources and whatnot.
Well, I think that's a great place to start. Let's talk about the sources. You said what was the flow rate we need to make this work?
So flow rate to make that work is unlimited. That needs to plug straight into the wall. Right?
Yeah, you cannot go off of the Christmas tree.
Yeah, right. Even though all that threading is exactly the same, it looks like it should work. It'll sound like it's working, right? It's not going to supply appropriate volume to your patient, right? Especially on in that setup there. Actually, it'd probably be worse in this emergent respiratory product if that was undersupplied, if you will, right?
And I guess one of the benefits to the other one is that you have a sight glass in it that's showing you where you're at. You only can adjust it to that on the other one. So.
You might get into a situation where you've turned the volume up, but you can't make. Yeah. You can only make 2.5 centimeters of water, and you're in trouble.
Definitely not at the 5 to 10.
5, 10, right. So I guess we can't state that enough. Pull your stuff off your truck. You got to know what you have. I know of agencies that have multiple devices. Like on one truck they've got this, on another truck they have that. Whereas my opinion is that's setting somebody up for, setting somebody up for, I don't say failure, but it's setting them up for a struggle. So they certainly, you certainly need to spend the time to understand your tool, and that goes with anything in the service, whatsoever. But here's a
shout out to Highland Heights Fire Department.
Bill jumping on there. He says, Bill Bernhard jumping on there. Says Pulmodine's been great. Used it multiple times since switched. Again, we spoke about this in the podcast. The one, I don't even want to say limitation. It's just one thing you have to be aware of that system. It's the FiO2 is 30-40%, right? So if you have somebody, you put them on there, you tune them up to 5, 7.5, 10 centimeters of water, and their pulse ox is still weak.
Augment it,
right?
Nasal cannula, high flow oxygen.
That's the great part about that emergent product. 100% FiO2, you get that right off the bat. Or, the downside, certainly as I see it, I spoke to it a lot in the first episode, is and the reason I transitioned my people to the disposable was simply because that mask is hard to put on, right? Yeah. And once it's on, it may actually in somewhat be
it's a hands-free BVM mask. We worked that out at Russell last night.
Yep. You want to demonstrate it?
We should, on me.
Yeah, why not? So why don't you talk about it?
We can do it. So you talk about it, we're going to demonstrate it.
Well, I'll be doing it myself then.
Okay.
And we've got we have a couple of
up top.
Up top there. Let me see that. Let me scroll down. We got a couple of good questions here that we should be talking about.
All right, we'll talk about those questions then.
No, you guys can demonstrate that. I mean, that's Caleb's thing. Every chance he gets, he wants to demonstrate this.
So, I'll walk. I'm your patient. What do you want to do?
You go ahead. You. I don't want to mess up your hair.
Oh, thanks.
All right, I'm going to go a little loose for you there. Okay. So we might not need this in the case of CPAP, but we formed a great seal, and this just so happens to fit here. And now I have a hands-free. I can walk around, and as I told the guys in Russell yesterday during that, I mean, I can squeeze here. I can get the meds out and squeeze.
You can
my neck.
multitask, right? Yeah.
But it's a great hands-free way of.
That's a great look for our medical director.
Yeah.
I'm glad we have this memorialized for all of you. But this is this brought up a point that John and I were talking about before you got here. Is there is no such thing as a therapy with no penalties, right? But we have such a low risk profile with CPAP. Even if we start down a pathway, and in my eyes, my concern is, decision paralysis, right? It's like, do we, don't we? It's one thing if it's a medication, or it's one thing if it's an electrical therapy, things you can't take back, right? We have to be 100% on those things. We all get that. But if something like CPAP, you can pivot, right? If we talked about that patient that, maybe starting to get a little sleepy. By the book isn't necessarily the perfect candidate, but is it worthwhile to trial on CPAP, right? Is it worthwhile to trial them on CPAP? What you just demonstrated is, oh, no, you know what?
So I've trialed CPAP, I failed the CPAP, but guess what? I
Their
can go right
stats
to
aren't
BVM.
improving. They still look like crap. You can just pivot, right? You can just pivot, and you've got, you can make sure they're well oxygenated, well ventilated while you're considering, do I need to do advanced airway maneuvers or anything like that?
And it's instantaneous. It's not like you have to wait for the medication to take effect. It's not like you're waiting hours for Solumedrol to take effect. It's immediate.
Correct.
Is that immediate intervention changing things? Or if it's not, they're continuing to deteriorate. All right, my course is laid out for me. They now need an advanced airway.
Yeah. And I guess I want to state that, more simply is you're allowed to change your mind.
Yeah.
Right? You're allowed to say,
Do it. Remember that?
Yeah.
Just do it.
Yeah.
Just do it.
You sound like a Nike ad, right? But yeah, it's safe enough. It's one of those things you should have a low threshold for tolerance, right? And just be like, yeah, let's try this, right? I can see you're really working to breathe, despite etiology. I think we spent a lot of time kind of going etiology by etiology, but just overcap the whole thing.
Yeah.
It doesn't matter. It doesn't matter what the etiology
systems to it. I mean, we have CPAP in our protocol, CHF, COPD, asthma on a worst case kind of scenario. But if we have COPD and CHF on top of asthma, and maybe we've started with the CPAP, now they've deteriorated, like you said, it's already there. Pop it off, pop the BVM on, get ready for the next procedure while I'm oxygenating.
So that whole change your mind and kind of feel things out was my not so subtle lead into that question there, which probably should mostly come from the physician.
Click it.
But
which one?
What's that?
CPAP
The
for
CPAP,
PEs, I
the
believe
CPAP for PEs. So you got somebody.
Check it. So everyone else can read it.
There, right there.
Nope. Other than just click on the text.
On the text.
Yep. Hey, look at that.
Hey, look at that! Fantastic.
One thing is working.
Yeah.
Where's Ray?
So, yeah.
Ray's
I
there.
see you.
I think he's in the International Space Station, but
Oh, I hear you
Oh,
now.
I do hear you now.
Can you hear me?
Yeah.
oh, we can hear you. Can they hear you? Is the real
I'm a
question.
I don't know. I'm a little distant, so if everybody out there can hear me, just give me a thumbs up or something, because I do have a little bit to add about the initiation.
Let's verify.
Works a lot better when you come here.
I know. I'm sorry. I'm double booked.
Yeah. You're live, Ray. Go for it.
All right, great. I think the big thing that Scott and Caleb were talking about that I agree with 100% is if you're thinking about utilizing CPAP, then use it. Apply it, right? So it's just like Caleb said. So if we apply CPAP and we're not seeing the result that we want to see, then you can pivot to that BVM. But if you are thinking, hey, I want to try to CPAP this patient, or CPAP pops into your brain, then do it, apply it, try it. Don't. I've seen one too many times people are so reserved to just apply it and try it. And most times when you do that, you're going to have a positive result. Your patient's going to improve. They're going to oxygenate better. If they don't and it's not working, then you pivot to the BVM, because what's the end all be all if CPAP doesn't work and then bagging this patient doesn't work? We're probably going to have to move to intubation, which we want to try to avoid in long term, or that patient ending up on a ventilator. We don't want that. So if we can prevent it, let's prevent it. Let's try it. This is I know I pound my drum all day long about this, but this is an EMT skill. This is not a difficult thing to provide to your patient. That's probably going to put a patient that's in severe distress, that's now going to talk to you the whole way to the hospital through the mask because they can breathe again, right? So it's just.
I think we get caught up a lot in the
supporter of it.
Contraindication side of CPAP, which really isn't huge.
That's that decision paralysis
Yeah,
I was talking about. Is
and
we focus on the what ifs, right?
And the one that holds a lot of people up. I'll wait till the hurricane was over.
Yeah, right. Sorry about that.
The one that holds a lot of people up, I think, is the history of blebs. If I have somebody who is on their circling and I elect to do the CPAP, I'm going to go to a BVM if they've gone out on me. And in that case, what do I care if they've had blebs or not? I need to fix the patient. Listen to lung sounds, listen for pneumos. Now, if the patient's alert and oriented enough to tell me that they've had blebs, obviously now that's a contraindication to it. But I would rather deal with a pneumo than death.
I feel a little differently on that. I think people focus on the hypotension, right?
I think that's a huge part of it.
The hypotension. Yes, it is if they are wildly hypotensive. The thing is you don't have to turn CPAP from 0 to 100 immediately, right? So if you have a soft blood pressure to start, feather it in, right? And if you get into trouble, you just back it off.
I think part of the problem, Scott,
right?
is if you read the protocol, and I apologize, I haven't. I came right from the medic class. We were not talking about CPAP today.
Oh, I'm shocked you could read. That was the big.
But I think the protocol says something about if you're going to use nitros, it has to be over 110 systolic, without an IV, obviously. But in any case, I think people see that 110 systolic and they think that that's written in law, that it's hypo, and it's yeah.
Right. So, you have a patient that lives at 100, 110 systolic, as their normal being. Well, they can tolerate that down a little bit lower. But yeah, they're, to raise point and kind of people are looking for these like finite action points, right? And oftentimes they're just not there. And this is a very safe intervention.
It's awesome that yesterday you asked the question. You said, what is the contraindications to epinephrine?
Yep.
And I said, well, somebody said being allergic to epinephrine. I said, well, how are we going to treat it with more epinephrine?
They need epi and Benadryl, clearly.
Yeah. So it goes back to kind of that same mindset. There's contraindications to things.
So my discussion about hypotension was, again, to circle back to that question about the PE, and I want to hear from Dr. Hill. But my initial read of that and my initial concern as a paramedic is: are we talking about massive PE? Or are we talking about a submassive PE? Right? If we have somebody just came back from a flight or a long car ride, or they have a history of
pain in the calf for a week leading to this.
They have a thrombotic or embotic history, right? And now we have sudden onset shortness of breath for no appreciable reason, right? But their pressures are okay, right? I think we need to differentiate if we're going to answer that question, at least in my mind, is that patient who's wildly different from the massive PE that has no blood pressure, no forward blood flow, and is actively trying to die.
Yeah, and there's nothing you can do about it short of giving thrombolytics, which you guys don't have.
Correct.
So there's nothing you can do for that. But
Identify.
Yeah, you can identify.
Triage.
Yeah. Treat with diesel.
Yep.
Call your local hospital.
A couple of big ass IVs.
Yep. Tell them what you got coming in, so we can be ready with it. Because those are the patients that have a history of blood clots or PEs, and they look like a submassive PE that maybe is a saddle and now broke off, and now they're peri-arrest or arrested. We need to know that coming in, so that we will have your medication drawn up, and that's the appropriate patient we're going to use our
And I think most UH
thrombolytic
facilities have a PERT team, though.
Yes.
So it's activated just like you would a STEMI or a strokes, and let the docs know when you call into the hospital, hey, activate the PERT team. I'm coming with a possible.
Something we probably need to spend some more time on in this
Yeah.
forum, right?
Well, I know there's somebody wants to talk more about pulmonary embolisms in the future.
He does. Yeah. I don't even know. I don't know that I know who Matt is, but you know,
He's a good guy.
he's certainly he certainly hit a point for me. So, but you know, in my mind, that's what I would look at it. You know, does it present as PE? Is the story there, right? And then you know, is this massive PE, which it's going to peri-arrest, right?
Correct.
And this patient's going to be, you know, even though we've tried to intubate him, even though we've tried to oxygenate him, we've got the FiO turned up, we've you know, we've done all these things, and they're just refusing to oxygenate. You know, that's making the case for massive PE, but that's submassive. You know, with this story of just sudden onset, can't breathe, doesn't, you know. If they've got a pressure, then yeah, like we
You
just
got
said,
so many more abilities
we
in
can
the
throttle
ER
throttle that
setting,
in.
too. I mean, D-dimers and chest X-rays, we're just not going to have in the squad. It's a tough diagnosis. I mean, also you talk about S1Q3T3. I don't know that I would ever see it.
Yeah, I think I was telling somebody I've seen it. I've seen it 3 times, and two were. It was pointed out to me after the call. It was just like, "Hey, look what you missed!" Right?
right, and of course that being the EKG changes with a possible PE. I don't think I would ever have the know-it's-all to look for it unless I strongly suspected a PE and said, you know, I want this for the students.
There's other things.
A good doctor once told me, though, that the first identifying factor of a PE on an EKG is going to be tachycardia.
Tachycardia,
And that's a
tachypnea,
great,
right.
yeah.
So without turning this into a PE lecture that I want to do, we're going to do that another day.
I don't know, Doc might have a PE.
He's yeah. I have a bad joke. I'm not gonna say on air.
Oh, it's for later, huh?
Yeah. And Fallon, you jumped in there and had put a bit on there about covering up, and I assume you mean
Oh, for the squeak?
covering up this venturi here, right? So this is an air intake. The way these systems work is we plumb in that 50 psi source gas, 50 psi oxygen straight out of the wall, and it's entraining room air to make the volume at the mask end. We got to stay away from this. This is no-go land. We can't be putting things over this. We can't wrap this up. Can't tape this up. No duct tape.
It's actually there for a reason.
It's actually there for a reason. It's also the reason why this is a lower FiO2 system, right? Is because we're sucking in 21% room air, mixing that with our 100% source gas from the. I would assume in most people's application from their truck or from their portable bottle. That's mixing in that tube. Not 100% FiO2 at the other end, and that's the warning about and the discussion we had on the recorded podcast about making sure you got a nasal cannula on underneath so you can augment with as much supplemental oxygen at and under the mask as possible, right? So
So to answer the question,
Don't
you
cover-
probably shouldn't cover that with
No,
a
no,
glove
no.
to stop the squeak.
I think that would be in the strongly recommended bad column, right? Again, recap the big thing for me. Certainly, why I accepted. Again, 100% FiO2 for this emergent respiratory products. It's fantastic. It's fantastic for that. It's very easy to use, but in my mind, and why we switched to a consumable and augment when necessary, is because the mask is almost a barrier to therapy for delivering specifically nitro and CHF. We see a fair amount of CHF in my clinical world, and we don't want to interrupt them getting constant nitro.
Uh-oh.
It's always
Oh,
it's,
man.
it's always something.
Always is something.
So,
Like-
okay, hold on. Ray may get detuned in 10 minutes. So if he's got stuff on his mind, Ray, if you got stuff on your
Take it down
mind,
quick.
yeah, you need to
Yeah,
brain
quick.
dump right now.
Go.
No, I think
Just roll.
everything you guys are talking about is great. I wish I was there in the studio with you, but one of the biggest things too is how we apply these. So if they're improperly applied or per se plugged into the oxygen source the wrong way, then you're not going to get any good flows. And that's one of the things. People that use the Pulmonine, you have to make sure that you're actually plugging it into the 50 psi port, just like at my place we use Emergent. So one of the things that we utilize is we're always plugging it into the 50 psi outlet, and that's why I'm pro both of these units. I like Emergent, but I also like Pulmonine, and you're plugging them actually into a 50 psi outlet versus already a regulated down pressure. Caleb, why are you giggling?
Well, Scott's trying to figure out his phone.
Yeah.
Oh, okay.
We're having a.
And you can't cover the filters either. That's one of the flaws we see with Emergent. I know it's a small thing, but for years I watched people take
John,
that filter and just
I just
throw
got it up here.
And
I'll just look
I
at
just
it. We'll just
shook
look at
my
this.
head.
No, we'll be fancy.
Shook my head
okay.
because that's what's protecting us. That's an excellent relation. Essentially, HEPA filter and N95 filter we have to think about. Just like the Pulmonine unit, you can't occlude any of the intakes or outtakes of that unit, or it's not going to function properly for your patient.
No, you actually brought up a good point too about there being the filters that are built into the system. Obviously, filters are great. Filters are great, and why not utilize them when they're available to us? With the older system, we had to put one in line. With this one, it comes with it. So it just has a lot of pros that I see outweigh any con. I like the mask fit better on it. I like that it has several adjusting points. The old yellow one just kind of smushes on the face and you hope for the best. So, did you get it?
Boundtree was placing. We're looking at some other comments here.
There we go.
There we go. Boundtree is placing end-tidal CO2. Last company did not have it. Do you know if this has changed? So that goes to my original statement is actually I think it was more offline. Dr. Hill and I were talking is. Somebody can order the wrong thing, right?
Yep.
You can grab it from a different hospital.
Well, and obviously
there's,
without it, it's going to be a little cheaper too. So
Or they get packaged the wrong thing.
they get packaged the wrong thing. It's there's a bunch of vectors to get all that stuff wrong, right? So it's probably
do you have one sitting there?
what's that?
This
An entitled.
Yeah. So obviously they're talking about these.
Yeah.
And
Yep.
having these in the bag
Yep.
already, and having end title with it, that's awesome because not only do you have that augmentation of extra O2 if you need it, but you also have the end title attached to it.
So so Susie, to answer your question, it's what we have asked them to make up the kit that we've asked them to make up. Yes, is supposed to have it. Does that mean that whoever was pushing the button at the hospital and ordered it did it exactly correctly, or somebody didn't steal it out of there because it is overwrapped? I guess in theory somebody could steal it out of there, or came into your system through another vector. Maybe that's the the point. We just got to constantly pay attention to these things, right? It's same as if you have the emergent respiratory products, making sure you have a T-piece if you're going to use a nebulizer. Not every T-piece out of every nebulizer set fits in there, right?
You're right.
There's some that the diameter is completely different, so you can't just check out your truck and be like, oh yeah, I've got one, I'm good, right? It's got to be the specific one that fits that particular setup. With the correct adapter sizes on both ends, or again, you're gonna find yourself in a bad place. So,
All right, we'll go back to another Matt question. Is there a typical timeline for COPD patients who are being hyperoxygenated to decompensate if left on CPAP too long? To your first question, Matt, yeah, use CPAP for your PEs as long as there's not any other contraindications for it. It's going to give you a little bit of pressure, especially if they have other comorbidities going on. But yeah, CPAP's okay for your PE patients. Now, Typical timeline for COPD patients who are being hyperoxygenated or decompensated if left on CPAP too long. They're not going to, if a patient is on CPAP, there's no such thing as too long. So remember, people that have these respiratory diseases, they are on CPAP all night long. They're on 8 hours a night on their...
They're on all night long.
Yes. So they're on 8 hours a night for therapeutic reasons. And honestly, we leave them in the hospital for 12 hours, even 24 hours. If I can leave a patient on CPAP and not have to intubate and take their airway, I'd rather do the non-invasive standpoint. So if they start to decompensate on CPAP and you've maximized your settings, meaning you've maximized your FiO2, you have nasal cannula on board, so you're giving even more FiO2, and they're still decompensating, that is your clear path, and now you have to take that airway. So that's the appropriate next step.
Without putting words into his mouth, maybe that angle has a little bit to do with the increased FiO2 and the hypoxic drive, right?
Sure.
I think maybe some of that question is rooted in historical teachings and classical teachings of the hypoxic drive and some commentary there.
So your COPDers are going to be used to being hypercarbic, right? And we see that on blood gases. You're going to have a normal pH, but they're going to be hypercarbic. And your body is driven by that acid-base disturbance, not necessarily the oxygen level. Your body has those sensors. They don't really get used, though. And hyperoxygenation can be bad. However, in an EMS setting, that transport time that hyperoxygenation is not a concern. Right. So I wouldn't worry about oxygenation for this. And this is why what we do for CPAP is we'll start them off at 100% in the emergency department, and we'll check every hour to see what their blood gases are doing. We will titrate down their FiO2, but keep the pressure up, and that's what the important part of CPAP is keeping those pressures high.
You have respiratory therapists that are going to spend full-time attention on optimizing that FiO2, where our job, if you will, is, put the Band-Aid on, deliver a salvageable package, right? Yep. And then you guys will fine tune from there. I suspect, let's leave the realm of CPAP. If you have to go drop a tube, you go to work tonight, you drop a tube on somebody, you probably start 100% FiO2, you let them run for a couple minutes, and then you're like, all right, then respiratory comes in and dumps that down and starts seeing what they can get away with minimum, right? Because without going into a whole discussion about oxygen-free radicals, and I mean, we can go down a really deep hole here. But
brewer reflux.
We got all kinds of stuff, but it's up to you guys to fine tune.
And it's our respiratory therapist, and we talked about this in prior podcasts. I don't know if it was in the CPAP one, but you guys have a great provider to patient ratio there.
Yes, right.
You come to my department, if I'm the only doc and I've got 20 rooms, I'm 20 to 1. Respiratory therapy is much better than that they've only got a set amount of patients. That's all they're doing, and that's all that they're worried about is those vent settings and or those BiPAP settings or CPAP settings. Right. And that's what they do. They might ask me for a gas order or, hey, I'm going to do this. I'll be like, yeah, that's...
They're going to optimize it.
Correct.
Yeah.
Which is great for me.
Right. I mean, because that's cognitive offload for you.
Oh, yeah, absolutely.
Yeah, if you were a one-man band in a standalone ER, it'd be a whole different... You'd also have 4 patients a day. So.
Yeah, and we can talk a lot about cognitive offloading as well. All right.
What do we got here?
From Abby, they told us during the pulmonary in-service to keep the CPAP tubing scrunched together in the middle and extend at the ends to stop the whistling.
News to me, Abby.
Well, yes. And if I took this apart, I think you can prove that without throwing everything around the table. Let's see if I can actually do this and make it make sense. All right, so if I took this tube and went like this, do you hear anything? I'm telling you, so do you hear anything? No. Now, if I made this
I'm
and I did it, you're going to hear it.
Right, yeah.
And that's kind of what they were teaching when they came out. The biggest reason for the extension was just for the extension.
Sure.
So if you didn't do that, you have less of a whistle. And maybe you can... There it is.
Yep.
So if it's shorter, you're not going to get the whistle. And that's kind of how they explained it. And obviously, if I could have a lot of room, I would whip that thing around.
But yeah, certainly that should not affect.
No. this same supply.
Yep.
So-
That should not affect therapy whatsoever.
I would argue you're going to get better supply because we can talk about length and
Sure, friction, basically
Yeah,
friction
friction
loss.
loss,
Yep,
yeah.
yeah, friction
Friction
loss.
loss.
firefighters-
we lost.
Yep, there we go.
shorter.
But that was the whistle, and I think that keeping it shorter is better. But if you had quite a ways to get to your port, that was why it extends.
Yep. But to the original point, don't
Don't put a glove on there.
don't block that. yeah.
don't block that Venturi inlet port because that's
Certainly, that would probably stop the whistling too, though.
indeed.
Also reduce your effectiveness.
Voltaire says.
So going back to about supply ordering, if it came from EMSI, clearly it was ordered correctly. Because we're not human and don't make mistakes.
Right. But to Bill, I guess I mentioned it earlier, and piggybacking on Bill, the hospitals also order some of this stuff too. It doesn't all come solely. There's not one guy for the MSI that does nothing but deliver the correct.
I have not yet been to a facility though that doesn't have, or should at least have, a bunch of these for EMS. So grab one if you're exchanging and put it with your kit.
Yeah, I mean, just take quick inventory of the stuff when you pick it up, right? Make sure you've got your, make sure you got all the parts you need, regardless of the, what device you have here. So.
I really kind of want to whip that thing around.
No, I'm glad. No, ultimately, I want to get clobbered on Facebook Live, and I'm not looking. I would not necessarily be looking forward to that.
That would be great.
Yeah, trauma resuscitation on
Yeah,
Facebook Live.
why not?
All right, let's see here. Anything else we need to? And thank you all for jumping on here with some comments. This is what we actually wanted it to.
There was a question that came up yesterday at Russell's. So Russell held an advanced airway lecture with Dr. Beck, and Dr. Hill was there, and UH's AirMed came. It was a great time. A lot of hands-on skills after the lectures. But they had a lot of good questions that came out of it during the groups, and one of them was, you have a patient who you put CPAP on, they vomit into the CPAP, what do I do? And it seems so simple, but it's not. So what would you do?
Strip it.
Strip it.
Yeah.
Go to a BVM if you have to, because then the follow-up question was, well, they needed the CPAP, and I was told not to take them off if I started it.
Yeah. So.
Do I want aspiration?
So I mean, that kind of goes to some of our previous discussion about people are looking for very fixed.
Written in stone.
Right? It's written in stone. It's
you're not going to have that.
Medicine is grayscale. Medicine is absolutely grayscale, and this is one of those things. Like, well, I mean, if you read specifically the way the protocol reads, it's untreated vomiting, right? So, that's probably the same mindset that's like, oh, they vomited earlier today, I can't use it now, and that's
you can.
Yeah, because all right, I've given my Zofran, I've given my.
Did you check your QTU interval first?
I have. I ran 312 leads at least, right, and transmitted every single one of them, but we've given our Reglan, or we've given our Zofran, and the patient is not retching. The patient, is saying they're better, but they're still high. They're still not oxygenating, or they're still dyspneic on nasal cannula, non-rebreather, whatever. By this, in that same thought process, if they were really hypoxic, would you put and they were still nauseated and retching and vomit, and threatening to vomit, would you put them on a non-rebreather? I think most people would be okay with that, but they understand instinctively you got to be there to rip it off, right?
I think that there's two exceptions to the don't take CPAP off rule, maybe three: cardiac arrest, vomiting, and nitro.
Yeah.
Break the seal.
Break, but it's not even taking it off, right?
You're not. You're just breaking the seal.
You're enhancing therapy by breaking that seal specifically for that CHF patient, right? And these guys know that's just a weird, a passion of mine is
raise back
is making sure that those patients that that have CHF are getting the underlying treatment, the underlying causation treated with nitrates, and not just the side effect of the CHF, which is the pulmonary edema, treated with with CPAP, right? When we would tell basic EMTs, hey, once you put it on, never take it off. Well, that's kind of short-sighted. We're asking you not to take it off if there's EMT audience out there, because if you snatch that off, you've done nothing to address the
Flash pulmonary edema.
Yeah, you're setting them up for flash pulmonary edema. You've done nothing to address the underlying cause, right? With, heart failure, right to left blood flow. You're doing nothing to address that, right? So all you do is you push the fluid back, you hold it back, and then you snatch it off, right? You're setting them up for a position where, okay, now he's intubating them, because they're drowning, 20,
And I think that's
20 minutes
exactly
later.
the scenario we played. It might have been on the episode or in one of the CEs we did. Was that's what's happening. You had a crew bringing somebody in on CPAP. What's the first thing the nurse does? I want a room sat. So the CPAP comes off.
Yep.
Squad clears with a 99% sat on their patient. But as you're cleaning your ambulance, they call respiratory to the room stat, and they're intubating a patient.
Poorly,
So
right? So
it was important, and that was at the time we had drilled it in that, hey, if you've got a patient on CPAP, explain to them that this was the case, and you had wet lungs or what may, or did you do the nitro? Hopefully that way we didn't have the flash pulmonary when you took it off. But speak with the docs, make sure they know that, hey, they're about to go into flash pulmonary.
we did a thing, and we
Yeah.
didn't treat the underlying cause. Now, having said that, for the advanced providers that are watching, right? Again, you got to break the seal.
Yeah.
Give the nitrates, but there's I've also conversely heard people say, I put the CPAP on, they looked great, so I didn't add. I did, and
But they look great because the CPAP's on.
because the CPAP is
And the alveoli is clean right now.
Correct.
And then
correct, but you've not treated the underlying cause. You've only treated the side effect.
it looked
right?
like Ray wanted to say something. Nope.
No, I think it goes back to, this is kind of looping into your point to the underlying cause, for that shortness of breath patient that has pneumonia. And we talk about people and the way they follow our algorithms for the protocol and follow the tree. And it's, to some people, that gray area is they don't know what to do. It's like you have to think outside the box.
Right.
Can I CPAP this patient that has pneumonia? Well, yes. What's the underlying cause that they're short of breath right now? Because there's a bunch of fluid, they have an infection, and all that fluid is covering the alveoli sac. So, maybe if I sit my patient up and then put my patient on CPAP, now they're going to be able to breathe better. Well, I'm worried about pushing that infection around, right? It's just like, Caleb, it kind of ties into your vomit question. Everything's not going to flow in that perfect order for us ever, right? It's just, we jump from bad to worse sometimes, and we have to know how to navigate that. There's not going to be any algorithm for that. You have to have some critical thinking for that.
No, he's right.
Sorry if I sidebarred that one, but
No, not at all. That was exactly the same vein.
Yeah. I see a really good question that just popped up. I can't see who it's from, but have you ever heard of CPAP being used for a near drowning? I think that's a great question for Dr. Hill.
Oh. Now we're fighting. All right. Have I heard of it? No. Does it work? Absolutely.
Absolutely.
So, again, CPAP's going to be for anyone that's in respiratory distress. It is going to be your step before you're required to intervene in the airway. So, patients in respiratory distress, absolutely put that airway on and reassess them. If they're either going to get better, they're going to get worse, they're going to stay the same. If they're getting better, staying the same, great, keep it on. If they get worse, again, your path moving forward is clear. It's what your intervention is not working. You need to go to the next step.
So there is. I actually took the patient on the backside, on the transport side of to the trauma center from a freestanding ER, but on a near drowning, there was a guy that had a seizure, fell into his pool, and of course aspirated enormous amount of still breathing, seizing in his pool, and the squad did bring him in on CPAP, and he wasn't doing great, but he was certainly doing better. He was in status. He subsequently did get paralyzed, sedated, intubated.
Yep.
Something to break that chain.
So when we went and got him, and he was clearly still intubated, but they set him on 20 centimeters of water. Of that's
It's a lot.
That's our max.
They had him completely cranked up on the ventilator, right? And remember that the PEEP on that ventilator is the same as the PEEP valve that's on my that's on my
Yeah, I think 20
consumable.
shows
And
in the warning for us even. So
10,
it's
10 on
yeah.
that, it'll be 20 in here. And then, PEEP and CPAP physiologically at an alveolar level, it's the same thing, right?
Yes.
It's measured centimeters of water. It's you're doing the same thing, one kind of actively, one kind of passively, but same physiological function, right? So this guy had, was tuned up to, 20 centimeters of water, and we ultimately wound up stepping that back before because we'd pushed any fluid out of across the alveolar plane, and he'd begun oxygenating. He didn't need all of that, so it was staged back, half for his blood pressure that kept trying to crash, and half because he simply was oxygenating fine on that. I know Fallon's laughing. She remembers that
She
call.
is,
Did she?
Yep.
I was going to say we had that case. Yes, I still have nightmares of that case. Yeah.
I think truly CPAP's underutilized in a lot of ways. Think about CO poisonings. I mean, in the awesome way it would help with just eliminating some of your guys' work in the ER if we started that early and blown the alveoli clean. And it's just something to think about.
Yeah, I mean, what's our options for hyperbaric oxygen anymore?
I think most people have them for wound centers, but
nah, I don't know if you can.
Not emergently.
no, not emergently.
Scheduled, yeah. Emergently,
I'm
no.
going to schedule my CO
exactly.
poisoning.
Yeah.
But I think it's maybe rotor trip to Toledo is I think the closest, because there was what's that?
Pittsburgh.
There was availability at St. Vincent Charity for a long time, and that's now not an option.
Yep.
So
But
that might
CPAP's
be
perfect for this, though.
We have to. That's our.
I
perfect
don't
ratio.
remember. I think Dr. Spanner said at one time how much it actually cuts down on the time, but it's well above half. I thought.
It does. And honestly, most people don't need it. But if you need it, you need it.
You need it.
Right, yeah.
And I think that going back to some prior discussions and I running around trying to make all this work, we've tried to simplify CPAP to once you start it, keep it on because we don't want to interrupt it. And think about CPR. We're big about limiting the time off the chest. And we want to limit that any time we're going to be off the chest to less than 10 seconds because all that forward momentum that you have with every treatment
You could lose it.
You're going to lose it. We don't want that to happen. Where if we're going in a good direction or if we're even just maintaining and not allowing whatever situation is happening to get worse, we're doing a good job.
But just to make sure that interpretation is limit the time off.
Yes.
Right. There is not a moratorium on
Correct.
ever breaking
Yep.
the seal.
And the point is you're always going to be reevaluating, right?
Absolutely.
Even with CPR, you take those Q 2-minute breaks, Q 4-minute breaks, whatever it is, whatever algorithm you're processing, to check for pulse to see if you have ROSC, right?
And
So
if you are such a stickler on the pros and cons and all that, and you've read the protocol, I think it alludes to every 5 minutes if you're on CPAP, you're trending vitals. So you should catch this.
Yeah, and I don't know if it was this episode or one of the other ones we've recorded that hasn't hit the air yet, but we harped on that a lot. It's like you got these, you can't rely on yourself in the heat of the moment to reach over and hit the NIBP button to reassess blood pressure. It's fun to watch people's trends who think they do it well, right? Because there'll be like these 7-minute gaps, and then there'll be like 4 and 30 seconds, and it's like you didn't even get the results, and you started it over again, right? So use the tool in that particular.
Set your time.
Yeah, just set that.
It's so easy to do. You scroll over to the vitals, click it. If you're using a life pack, you click it, set the time.
Dump the interval down, let the machine do the work. Every time you glance over, you're getting, new physiological data to act upon rather than stale data. It's one of those, you feel like in the moment you don't have time to do it, but it actually, smooth as fast. Yeah. It's take that extra second. It will ultimately benefit you in the let's John has put this down on the keyboard and has
I was wondering what was happening.
I'm pretty sure he may have just messaged all of you, DM'd all of you inappropriate things in mass quantity. We apologize. The Institute as a whole apologizes for this. Was not our
For
intent.
any intentions or non-intentions.
So, but no, thank you all for hopping in here with these questions. This has been fantastic. Kind of exactly what we were hoping this would turn into. Something a little light, a little fun, and not so much just us bantering back and forth. About
Pick
that.
our brains.
Oh boy. And then we're coming up on our
1 hour.
on our 1 hour here. We promised, unless you guys were just rattling us with a bunch of other questions, that we would try to limit this to an hour so you can have the rest of your Monday back. But beginning next week, next Wednesday should be the release for.
Hey, you almost started talking about that.
I did. I was trying not to. The John's going to have to take that. I'm not properly equipped to have that entirety of that conversation. But the next month, which is next week already.
Next week.
What's that?
It's Wednesday.
I know, but it's next week.
No. It's Wednesday.
Oh, it's Wednesday of this week.
Yeah.
Oh my God. yeah. 28 days, March. All right, so coming very soon, sooner than Scott's brain has wrapped his head around, is we have operational pharmacology with Dr. Spanner, and same thing. That's going to be split up into 3 bits, right? And those will be released the first 3 weeks, and then on the 4th week, we intend to get Dr. Spanner, and I think that was you, me, Dr. Spanner, and I believe Ray.
I think Ray was there.
So, yep. So some combination of us will be back with you. We'll be back with you live, kind of summary with that, and hopefully there'll be some pharmacology questions, regarding those 3 episodes. And
Never mind the panting; it's just Hank.
it's just the dog. we had a special visitor during that recording session, and we'll see we'll see how much you can hear of him on said recording.
So back to Matt again. No concern for free radicals with CPAP. Not at least in the setting of EMS and short transport times. You're not going to get those for a long time.
Yeah, if ICU, different story.
Yeah, different story,
Yep.
different management.
Yep. Different management. Yep.
And that's why we have respiratory therapists and intensivists and all that
Pulmonologists.
stuff. And so,
Yep. Any data or comments on pressure delivery between the two? I had a question recently.
Oh, I think she means the 2 different devices.
So between the plastic and your yellow box.
5 centimeters of water on one device is 5 centimeters of water on the other. Pressure's not the concern. The FiO2 is the big difference between the 2 of them, which is, goes back to what we opened with is, you got to know your product, got to know your equipment, and that really kind of goes back to that. Next topic for the live, operational pharmacology, Susie. Dr. Spanner, and there might be a lag here. I may have already said that, and then you're beating me to it. But yeah, operational pharmacology. So we're going to talk about. Let's see here. We talked about TXA. We talked about ketamine.
This was like October or even earlier that we recorded it.
Yeah, so we're. As a matter of fact, I got to record a bit to update. That episode still refers to TXA as 1 gram.
yeah.
So we gotta put a little disclaimer in there, make sure that gets out before.
And if you
confuse
guys,
people.
for those of you that are watching us or even listening to us after this was recorded and then launched on the other platforms, reach out to us. Reach out on Facebook or personally or whatever, and say if there's, hey, I want a topic to cover. So I want to have this next topic covered. We'll make a article for it.
Ray.
Yeah.
Susie has
This question is for you, Ray.
This is Ray's entire fiefdom here. When was the last time anybody calibrated the yellow box, Ray?
So at my place, it's actually within the past year, believe it or not. So if you have emergent,
Yep.
some people don't know this, but you're actually able to, if you go to Emergent's website, they have like a service ticket or a form you can fill out, and you can send your unit back. It used to be about $100 plus shipping, I think, to them. They cover shipping back to you.
Yep.
But check out their website. You can actually send your unit back to Emergent. They will make all the necessary repairs, service it, and then ship it back to you. And I did that to all 4 or 5 of our units,
Yep.
and they all returned like they're brand new. So I totally recommend to do that. Yeah, because a lot of people purchase these units and then do not service them or have them serviced by the company.
Yep. They just bang around in a compartment until they're used, right? And
We've had these for 10 plus years.
oh,
I think.
10. I think we're coming
20?
I think we're coming close to 20.
We're getting old.
But yeah, it is it's a piece of biomedical equipment, just like your cardiac monitor needs to be serviced periodically. And that's and I don't want to say that
That's a
is
great reason to have the disposables.
and that is a that is a decision point for departments on what direction you want to go. As far as the systems, CPAP systems you're going to use, are you going to do the appropriate biomedical service to make sure that you are delivering actually what the dial says to your patient, that you are oxygenating them appropriately, delivering the correct FiO2. So yeah, yeah, that's Ray's pet peeve, Susie. That's funny you brought that up. So we can't get him to stop talking about it. Actually,
Every time I see him, hey, how are you? Hey, have you
did you,
calibrated?
did you calibrate your box?
Listen, Chief, I'll get to it.
All right. That being said, guys,
that's a wrap.
I think that's a wrap. Thanks for you playing along and dealing with some of our technological incompetence here as we're working through this. I wish everybody could see how much stuff is really behind us. There's quite a lot of gear here, and the fact that we can get any of it to talk to each other is kind of amazing. So
Picture your bathroom and put all the gear in it. That's where we're at.
yes. This is a wide angle camera. This really is not as big of an environment as you would think it is. And likewise, any ideas, stuff you want us to cover in the future, throw that down in the comments. We obviously have, like I said, we've got half a year's worth of stuff already canned and ready to go. That's going to be released, but we want to do stuff you're interested in, not just stuff we're interested in. We got some starter pieces here, and give us ideas and stuff that you want to see, or problems that real time problems. And turns out if we don't know, if we're not experts on it, then we probably know somebody who knows an expert on it. We could probably get them in here. So.
Yeah. The one additional thing that I had a text message that this person will go nameless. Should have sent it in. And we have a episode about this also. Making sure that you guys are documenting your interventions, making sure that you put it as an intervention and what those settings are, so that way you get credit for it. That way you get your
Credit for it.
well, basic to advanced level of support, right? What you're doing, and then you can track your utilization that way. And we can also track to see how many we're using, because when we say it's underutilized, we're going based upon the numbers that are reported in your system, right? So if you're not saying you're doing it, but you're doing it, we're missing out on that data.
Stated another way, you have to put the event in your PCR, so we can run a report on
So
that.
it tallies it. It won't tally off the narrative.
We can't run a report on your narrative to see what clever thing you said in your narrative. We have to run it on the event. So, and that goes to everything. And this guy here, John, documentation is very important. Maybe sometime, since you feel so strongly about it, you should come on and do a bit on it. I think that would be excellent.
I think he's coming in a future episode.
That may already be a canned episode. So. Everybody, thank you. Have a wonderful rest of your Monday afternoon, and thanks for playing along with us. Have a great day.